We're talking so much more about menopause these days, but there's one big piece that's missing from most conversations, and that's bone health. Our bone health is so critical to our longevity, our health span, and yet so many women don't realize that they're missing a big piece of their health that they could be doing something about, even in their 20s and 30s. That's why today I'm so happy to have Cindy Dupuis on the show. She is a functional nutritionist who's been in the game for over 20 years. And she's now really specializing in women in menopause because she's had her own journey of going into early menopause at 43 and has had to learn through her own experiences, but is also now supporting women through this and really looking at a full picture view of menopause and our health during this change, how things like our estrogen levels are really impacting our health, including our bone health and our even our digestion, which we get into a little bit here. And it's just really, she really brings so many very practical insights into why we should care about our bone health, what we should really know, what things put us at greater risk of having lower bone density and what you can do to advocate for yourself with your doctor, in your lifestyle, to support your bone density now and into the future before it's too late. And even if you already have things going on, what you can still do. So I hope you enjoy this. I really think it's such a great conversation. Cindy, thank you so much for being with me today.
Well, thank you for having me. It is an honor and a privilege. Yeah.
So, as we get started, I'd love to hear first your journey into, really specializing in women through menopause, kind of supporting women in that transition.
Well, um, I've been a functional medicine nutritionist for a little over 20 years. And so I've been helping both men and women, along that path. And I moved into perimenopause and menopause partially because I've been in this space myself for about 25 years, believe it or not. I went into menopause kind of young. I went into it
Hmm.
when I was 43.
Hmm.
I was going through a very stressful time in my life and, kind of threw myself through the stress and losing weight into menopause. I was having periods and then I stopped. The body says, hey, we don't have enough support. We don't have enough cholesterol. We don't have enough fat. We're just done. And even when I kind of righted myself a couple of years later at about 45, my body says, we're not going to turn it back on. So I've been in this space for a long time. And I was watching some of my own personal clients, women. I knew how they ate. I knew their lifestyle. We've been working together, so I knew we had a lot of things dialed in, but yet we were still losing some ground. So I kind of thought, there's another piece here that I really need to look at. And then I was looking at my contemporaries and watching them lose their vitality, be in pain, become less mobile, seeing the doctors more, getting more procedures. And I had been on HRT for from age 50. So I've been on it for about 18 years. So yes, I'm 68. So I've been on it for a while. And I can see the difference between myself and most of my contemporaries. And, I used to ask kind of a cursory question of my clients, when it came to hormones, because this is kind of how we're conditioned. And I think it's definitely changed in the last 3 to 5 years as we become more familiar with exactly what our hormones do for us. It's just not siloed into this fertility, procreation, having a sex drive, right? Just that's it. But that's the question I would ask my clients is, how's your libido? And they would say, well, yes, it's dropped. But most of them, believe it or not, would say, my husband's not interested, so it's not that big of a deal. So I would drop the conversation at that point in time because I didn't realize all of the long-reaching benefits that our hormones have on all different parts of our bodies and the tissues and the organs and all of that. So that's how I got moved into the perimenopause space. And so I started doing a really deep dive probably about 4 or 5 years ago. And I haven't stopped because there's so much information, there's so much conflicting information. So you have to dig, you have to understand, kind of like the theories, like when you learn to play a musical instrument, you have to learn what's behind it. So when you start to understand what our hormones do for us, it gives us a better basis to understand if something's right for us or to have a conversation with our providers. It just puts us in a totally different space rather than, just the hormones treating the symptoms. If we have an understanding behind that, I think that helps us. So that's how I've gotten into that space, and I'm kind of on a mission
Hmm.
to help as many women as I can because sometimes I get lulled into this mindset that, there's so much information out there now on social media, YouTube, whatever, that women are hearing what they need to hear. They are getting the help possibly that they need to help. But I keep on getting women in my clinic that says, nope, that's not the case.
Hmm.
And so my mission is to reach as many women as I can. I've created a platform for that, a course for that, and to help women become their own advocates.
Oh.
Because, as much as we would like to sit back and have our doctors handle us, most of us, our doctors, we do see them for 15, 20 minutes. There's only so much they can do. And the other thing is to put this in perspective of why so many doctors don't know about perimenopause and menopause and hormone replacement. First of all, they weren't taught about it in medical school, which I'm sure
Hmm.
you're aware of.
Yep.
And part of it is a WHI study, part of it is that, and I just lost my train of thought. But understanding that because they haven't had the training and they're seeing so many patients that they're not going to have the bandwidth and the time and the energy to dig into it unless for some reason they have an impetus to do that. And often, and we're seeing this all over social media, it's, the ones that are leading the charge are the ones that are in their early to mid 50s. They went through it and went, excuse me. I don't think we have to live the rest of our lives this way. We got to look into
Mhm.
it. So, um, that's how I got into it. Yeah.
Yeah, I love that. Yeah, you're so right. There's so much more information out there. And I do agree. I'm happy that there's a lot more conversation around menopause and
Hmm.
how it can be done differently.
Hmm.
But that still doesn't mean, unfortunately, that we can go to our doctor and just say,
Mm-mm.
okay, let's have a conversation about HRT because there is still, the guidelines are still outdated. They're catching up. But then, yeah, the doctor is getting caught up with the update guidelines. There's not enough time in their day
Mm-mm.
often for them
Mm-mm.
to really understand. And it keeps happening. My mom-in-law even was asking me about HRT, got her all of her facts. She had her information ready
Good for
and went to her
her.
doctor to talk to her, but still she was met with, oh, they cause cancer. Like kind of pretty much door shut, conversation over. And I was
Dorsha,
like, wow. And she even came with all the data. She was like, can I show you these studies that, I so and
yeah,
so on a podcast was telling me, like she came in with
yeah,
information. She was so well informed. And
good
it
for
still was
her.
like, unfortunately, her doctor just wasn't at the same page. So yeah.
Yeah, and I just ran into that personally. I've been paying out of pocket
Hmm.
to see a physician who will prescribe, okay? And then I've been, paying out of pocket for compounded creams. I mean, there's a variety of ways of getting your hormones, the delivery forms. And so, new doctor, and I opted for an osteopath thinking that they're going to be more open, right? First thing she said to me when she saw I was taking hormones was, "You're still on hormones?" And I said, "Yeah." And I said, "I have no plan on going off." And she looked at me like, and I said, "And if this is going to be an issue, this is a crossroads for us, then we need to talk about this." So she was referring me out. But so I digress a little bit, but we just run into this all the time. And her
Mhm.
deal was heart disease, that
Mm.
clotting stroke, and that's again that is the
Oh, yeah.
form, that's the oral form that you might have an issue with.
Mhm.
And I've had, anyway.
Yes. Yeah. So much room for improvement for sure.
Yes, yes,
Yeah.
yes.
Well, today we're specifically talking about bone health, which I think is such an under talked about piece
Mhm,
of the puzzle.
mhm,
The conventional approach for bone health is let's just get a DEXA when you're maybe in your 60s, maybe by then.
mhm.
And so many things have already happened by then.
Yes.
I mean, maybe to start, do you like, what are your thoughts on that? Of like, is there a thought behind why we're not checking earlier?
You know, that's a really good question. I had to pause actually. It's like, okay, why? I think the why is it's happening below the surface. It isn't obvious, at least to the woman, okay?
Hmm.
But it should be obvious to practitioners because they're seeing osteoporosis in so many women who are 65 and older. And, a lot of my women are in that I see are in menopause, more so than perimenopause. And I always tell them, you've got to get a DEXA scan. And that's not an NLBL, but it's still kind of our gold standard that we go by. It's something that we need to have done.
Hmm.
And, Medicare will cover it when you're 65. And so a lot of doctors aren't in tune to having their patients do it unless they're a little bit more evolved. So you need to ask for it. So it's one of those things like, brain health, cardiovascular disease, bone health, and heart health. Or I say cardiovascular disease, one more. Anyway, those are the things that I think are below the surface of what's happening in perimenopause. All the symptomatic things are pretty easy to see and go, okay, if I give you a little bit of estrogen or whatever, those things go away. It's those things that are underneath the surface that are silent that aren't knocking at our door that we tend to ignore, right? Or aren't even aware of. And and I see in my clinic, I see a lot of women coming in with osteoporosis. And the thing is that we lose the most amount of bone, like 20%, in the first, we can lose it within the first 10 years of going into menopause. But
Hmm.
yet, if a woman's not testing her bones until she's 65, that's 15 years out for the average woman. Okay.
Hmm. Hmm.
That is a lot of room for bone loss, even if she is eating enough protein, even if she is, exercising and having weight resistance and putting that into it. And that kind of moves me into, if that's okay, unless you have
Yeah, yeah, go.
put, okay. Um, some of the risk factors, right, that we
Hmm.
don't think about.
Hmm.
And I want your audience to hear this because when you start naming these risk factors, it's a much better chance of a doctor ordering a DEXA scan for you if
Hmm.
you can talk their language, all right? And there's a reason for them to order it. Um, so one of the biggest risk factors, and I don't really like to use genetics per se, because I always say we can kind of turn our genetics around, and that is true. But I do find with osteoporosis that it really does kind of is handed down the next generation. So if that's a risk factor in your family, your mom had it, aunts, whatever, you do need to look more carefully at that, okay? And have it done at a much younger age. And what I like to tell women is to have it done when they're in perimenopause. So you have that baseline, and then maybe have it done again as you're going into menopause, and just, seeing how you're doing there. And then you kind of make the decision on how you and your doctor or you and how often you want to have the DEXA scan done and track it that way. And I am going to just throw something out before I forget it. And it would be really nice to have it covered by insurance. It's not an expensive test. And so you can order it yourself. You can walk into a lab and order it yourself. And I think it's 150 or under that. Okay. So it's not that expensive and it's well worth it. So yeah, getting it done in perimenopause and then tracking it from there, I think is a really good. So you can see kind of the speed of, you losing bone and like what's going on here. All
Hmm.
right, so risk factors would be, is it in your family? Another one would be, let's say, were you an elite athlete
Hmm.
when you were younger, especially during the years of your body building up bone? So that would be your teenage years up to about 23, 25 years old. So Were you an elite athlete? Were you getting your periods or were you not getting your periods? Because that estrogen plays a huge role in it. Were you restrictive eating? Okay. And here again, if you were and you weren't cycling, that is another layer of that risk factor. Have you had a history of taking steroids and even aerosol? So inhalers, okay, steroids. Steroids will also pull out bone. So if you have a history of that, then you need to watch it more carefully and probably test a little bit younger so you see what kind of support you need. Um, what else is there? If there's a lot of stress, cortisol tends to gobble up micronutrients, some minerals too. So it can deplete our bodies or our bones of the matrix that it needs to stay dense. So these are, I think probably some of the biggest risk factors. Caucasians and Asians tend to be more in that group where it's a higher risk factor risk group as well. So if you fit into any of those, pay attention to that. Do not wait to 65 to get your DEXA scan. Um, I would say, 50 and then maybe depending on how it looks, maybe 55, maybe 60, So yeah, you
Yeah.
can't wait. You really can't. And I don't know if women realize this is we think about breaking a hip. Okay, yeah, it's a little inconvenient. We got to go through surgery. It's a little pain in the ass, literally, too. But yeah, but the thing is that 1 in 3 women will not make it past the first year of having a hip replacement
Mm,
and from a hip fracture. And it's not because of the surgery itself. I mean, that's pretty easy to do. One reason is that a lot of those women, they're over 75, they're usually frail. And when you're frail, it's hard to come back to being immobilized.
mm,
So they never get their muscle mass back, they never get their mobility and their independence. And I don't know about you, but independence to the end is like a big one for me.
mhm.
It's like, okay, I'm going to lift those weights.
Yep.
It's not for the beach anymore. It's so I can
Yeah.
move right to the very end. And so that's one reason, the inability to move, the loss of mobility, and just a decline from there. But also, you can be more susceptible to an infection from the surgery. You can be susceptible to pneumonia because you're lying down, you're not moving, and you can be much more susceptible to UTIs, right? And they're often not detected as we get older. The women just are not in tune to the signs, and that can go to your brain, can go to your kidneys. So these are the reasons why it isn't the surgery itself. So it is a big deal. It's a big
Yeah.
deal.
That's so helpful, I think, to highlight the reasons why we should actually care about this. Because especially when we're in our prime, sort of speak of our
I
20s and 30s,
know.
we're not thinking about
No.
when we're in our hopefully 80s, feeling good, being independent, being able to drive ourselves, being able
Hmm.
to get up off the floor or even get up
Yes.
out of a chair.
Yeah,
Those things, you're right. Once those start to decline, it's so much harder to get it back. It's
it
so much
is.
harder if you do fall, you break a hip, then yeah, there's this, you know,
You are
downslide of all
fighting.
the things that come up
Yeah.
also. And yeah, it can make a huge difference of how you're actually living your life in your late.
Yes.
So, and to
Yeah.
go back to those risk factors, I feel like that's so helpful to describe also because I think a lot of people might not realize, oh, right, yeah, I had an eating disorder or I was very athletic in my teens, how that could actually impact your bone
Hmm.
health.
Hmm.
I agree with all those. One thing that came to mind too while you were talking is even like digestive issues,
Ah,
like ulcerative
yes.
colitis or something at its worst, but even just signs we're not digesting our food
Yes.
very well, then
Yes.
I've seen those people come in with like, they have no vitamin D, they have no calcium, because they are so nutritionally depleted.
Yes.
Even one of my good friends, I believe it was when she was 39, she like her because she was dealing with this, she did get a DEXA luckily, and she already had bone density loss. And I was like, oh my gosh, like let's replete you right now while we still have a chance. So the
Thank you. Yes. And, digestion is like one of my big deals because that's
hmm
something I deal with all the time personally. So thank you for bringing that one up. And yes, our minerals are not absorbed, broken down, absorbed, and our protein
hmm
too. It's
hmm
compromised if we don't have enough stomach acid, which a lot of people don't because of stress and blah, blah, blah. So yeah, yes. Thank you.
hmm Now, to take it back, you were describing a bit about how we lose so much of our bone density suddenly when we go into menopause. But what's sort of the normal trajectory? Like, when is our bone density at its highest? And then when does it start to decline even before we're in menopause?
It's at our highest, I believe, around 25, and it can start to climb, but on a very, very slow trajectory. It isn't until we lose our estrogen that it goes home. And, I don't think most women or even doctors realize that estrogen was approved by the FDA in 1975 to prevent osteoporosis. Okay. And then once the WHI study came out, that went off the table and
hmm
the biphosphonates came on. And, and you don't get a biphosphonate until you have osteoporosis.
hmm
So, and estrogen can still, help slow down the loss and maybe even be part of bringing some of that bone back as well. So, we kind of fall off that cliff. We were starting to lose some possibly during perimenopause, but we really do fall off that cliff when we have that senescence of ovarian function, basically. So when that estrogen just takes a huge drop, and if you're not doing any type of what's the word I want? Not extraneous, but outside replacement. Yeah,
hmm
yeah.
hmm Yeah, I think that's so good to highlight that, that has such a big impact on it. And it really is. I don't think people really realize how much, like you said, estrogen doesn't impact just our,
No,
cycle. It's really
no.
impacting everything in our body, including our brain, including our heart, including our bones. And it's such a big impact.
Digestive system too.
Digestive system. Yeah.
Yes,
Yeah. Another
everything.
one that's very not,
Yeah.
don't even think about that. Yeah.
No, we don't think about it. So, yeah, and I do have some clients that come in that don't want to go on hormones, and that's fine. It's a very personal decision, and as long as your labs look good, you feel good, your DEXAs look good, you're happy. There's nothing to fix here.
Yeah. That's
I
such an important factor to highlight that I
hmm
think some people get scared of like, I need to be on
I
HRT. I'm
know.
missing out if I'm not. And that's so great to say that, if you don't want that option or if that is an option for you for
Yeah.
whatever reason, you
hmm
might not need it. You could be
hmm
doing a lot of other things.
hmm
And on that
hmm
note, what other factors impact our bone density beyond estrogen? We talked about some of them sort of like with nutrients and things like
hmm
that.
hmm Well, protein again, right? Getting
hmm
adequate amount of protein is really huge. So keeping our muscle mass is huge and doing movement to stress. Okay, movement, twisting, pushing. And what we're actually doing is stressing our bones, which tells it that it needs to remain strong. So, walking is important, but putting some stress and having the strength to do that is really important. I know doctors will push calcium. You don't want to go overboard because there's a balance with everything, right?
hmm
Magnesium's not talked about enough, but we need magnesium for bone health as well. We do need collagen, and some collagens are better than others. There's some trademarks like Forte collagen. I would say it's probably better for building up that bone matrix. Um, you know, all the things that we need to do for anything else in our body to keep it healthy, lowering that stress. Sometimes we get stressed on, or we get stuck on the stress hamster wheel, and especially during perimenopause, when there's so much going on in a woman's life, typically, it can be really it's really difficult to get unstuck from that sometimes.
Mhm.
And journaling may not do it. You know, it might not be enough. So those are the things that vitamin D, of course, right? Vitamin
Mhm.
D, of course. So I like to see my clients, and you might differ here, but I like to see them at least 60 to maybe 90, maybe even 100, okay? Depending on her bone health. So those are the things. And then monitor, and maybe we can move into some blood work that I
Yeah.
think is really helpful. Um, so we do want to monitor with the DEXA scan, but I think Medicare covers, I could be incorrect in this, every 2 years, I think, even if you
Mhm.
show up having osteoporosis. And it's like, really? So let's say you embark on a new program, right? Of eating differently, of doing different types of exercises. And there's some bone programs that are specific to building bones. I can't remember off the top of my head what they are. But let's say you embark on something like that. Do you want to wait 2 years to see what the heck is happening in your body? I don't think so.
Mhm.
And it's too long.
Mhm.
Um, and so I like these blood markers, these serum markers for that, and also you taking, things into your own hand and getting another DEXA as well. So there's two blood markers. One is called CTX, that's the abbreviation. The other one is P1NP. And what I like seeing this because what CTX is measuring is the breakdown rate of the bone, basically. And we want to see the balance, and P1NP is the buildup. Okay, so we have two different types of cells in our bone. When it comes to bone density, we have osteoclast, which breaks down, and we have osteoblast, which is the buildup. And we need both. We need both. So I just had a client in, last week, and we did do these markers. Her P1NP, so her buildup, right? It's awesome. Okay. She's probably getting enough protein. She's, doing enough exercise. She also takes progesterone and testosterone, and both of those are an integral part of bone buildup. Where it was really not good was her CTX. So the breakdown of her bone was pretty high. I'm like, oh, look at this. We're not going to be going in the right direction for a long time unless we can get that boat turned around.
Mhm.
Okay. So it gave me a really clear picture of where the problem lies. Okay. Oh, I didn't mention this. Thyroid issues can be also a
Mhm.
risk factor.
Yeah.
And it made me think about it because of her.
Mhm.
So if we have hyperthyroidism or a suppression, oversuppression of TSH, which is your thyroid stimulating hormone, which is what I'm seeing here, that can really play a role in the bone breakdown as well. So
Mhm.
to see that in black and white can really help to guide us into knowing how to create a plan and direct the client or patient. Yeah.
That's so helpful.
Yeah.
And most women probably have never heard of those
Doctors
blood
either.
markers. So
Yeah.
yeah, that's really helpful. And with those too, there's so many markers that we look at that there may be a normal range, but we're looking for a more optimal range. For those
Yes.
markers, is it just in normal if someone's getting them and wanting to know if they should be concerned, or is there like an optimal range that you look for those two?
I don't know what the range is on the labs per se, if they have one, but I know what I look for in the CTX. I look for trying to keep it as close to 300 and not getting above.
Hmm.
Okay. 300 or lower. And then on the build up the P1NP, I like to see it pretty close to a 70, at least a 70. So we can see that it's being built up. And then there's a ratio, and I forget what the ratio is between the two that you want to hit.
Okay.
Okay. But there is a ratio.
Yeah, that's helpful. And with those, you mentioned some of the things then that can impact those. So like thyroid overproduction. Usually
Hmm.
we think of it, oh, my thyroid's too low, but people
Yes.
don't mind when it's too high because it gives them more energy. But even it being too high could speed up the breakdown of their
Yes.
bone then.
And and this is getting kind of into the weeds, but in this particular client that I was seeing this in, Um, her thyroid hormones themselves, we've been struggling with getting them up high enough, but her TSH got so suppressed that we had to, you really do need to look at the whole picture of what's going on and going, okay,
Mm-hmm.
stop.
Mm-hmm. Mm-hmm.
We can't suppress this anymore, especially looking at the bone. Yeah.
Mm-hmm. Yeah.
Yeah.
And what other, we mentioned some of the nutrient markers that you're checking also, like
Hmm.
vitamin D. Are
Hmm.
there other ones that you're finding really to be helpful, like parathyroid hormone or calcium levels, or those things that you see?
I don't check calcium levels. I mean, other than what's on, the CBC, but parathyroid is another good one to check just to see if there's anything going on there for, that's another piece of it. So you get a whole picture. So
Hmm.
thank you for bringing that one
Yeah,
up.
yeah,
Yes.
yeah, of
Yeah.
course. And you mentioned some of the other minerals, like magnesium, I believe phosphorus, and vitamin K too is another one that is finally getting some limelight too with bone
Yes.
health. But, do you typically check those? Do you think it's necessary to check those, or are we just sort of making sure there's enough in the diet and the supplementation?
When it comes to vitamin K, I mean, to the other ones, I don't test it. I do like to have vitamin K in along with vitamin D, right? So we're
Hmm.
getting
Hmm.
the vitamin D better absorbed into the bone. I don't test for that. Um, Magnesium, if you do test for it, I go more on symptoms maybe. Um, but it needs to be RBC and not just serum. Some doctors just do serum, which really doesn't tell us what is happening inside your cells. So it needs to be
Hmm.
RBC. So that actually is a good one to do if you can get your doctor to do it, or if you choose. We're so lucky here in the U.S. where we can order whatever we want, which
Yeah.
is really nice.
Hmm. Yeah, I agree. I mean, at this point, you can really order whatever you want yourself.
Hmm.
The hard part is the nuance, right, of understanding what they mean. And you can put them into ChatGPT or
Oh
something, but it
yes.
still doesn't quite, it can really
No,
miss the mark sometimes.
no.
But I agree. I think there's so much more access where, you can at least get them checked, talk to someone if they do seem abnormal, talking to someone about those. Yeah.
Hmm. Hmm.
And with all this, I mean, I think you've given so many great tips here to kind of reiterate, get an early DEXA scan.
Yeah.
I'm on that boat too. I'm like, why wouldn't we just do it even in our 30s? Like get a baseline,
Yeah, okay.
it, right?
Yeah,
I think that's very underutilized.
I
Um,
agree. I agree.
and, getting good nutrition, getting that movement in, jumping, putting pressure on
Yes.
those bones, getting the
Yes.
muscle going. Absolutely. Are there other things that we should be like watching out for, making sure we're doing? And maybe, I guess we didn't really talk too much about the diet too. Are there things that we can do beyond, like you mentioned, protein for sure? That's a really important factor.
When it comes to bone, I would say protein's probably the biggest thing that we can do. Of course, a varied diet, so we have lots of colors, right? It means that we're
Mhm.
getting a lot of different types of nutrients and antioxidants and just keeping us healthy overall, getting enough fiber. That's, usually if we have enough color in our diet, we're usually getting more fiber. And you brought it up, and thank you for bringing it up. Good digestion is huge, because if we're not digesting our food, absorbing our food, we're not getting the nutrients that we need. And the thing is that there's so many ways that estrogen affects our digestive system that not everyone needs the support there, but a lot of women need the support there. And one of the areas that happens is our production of stomach acid will go down, and that's where that protein digestion happens, and the ability to cleave our minerals and vitamins happens in the stomach there. So that goes down. And then we need bile, which we think of like we throw bile up right now. This is what I'm talking about, is what's made in the liver, right? We need bile for
Mhm.
so many different reasons. And estrogen plays a role in our ability to make choline, to make that bile. And some women, and I'm one of them, are more susceptible because of a genetic makeup. I have a genetic SNP, I have two of them,
Mm.
that makes it very difficult for me to make that choline and convert it into bile. So I need supplemental support for that.
Mhm.
And why is that important? Because bile has to do with peristalsis. Both stomach acid and bile um, kills the bacteria, okay, that comes into our digestive system. And a lot of people, as we get older, have more difficult time with the foods that we're eating, partially because of all those reasons I just mentioned. And we can have more sensitivity. So what happens is, so this can happen when you're younger too, right? We start limiting the foods that are in our diet. The FODMAP is a perfect one, right, for SIBO, right? We take
Mhm.
out all the FODMAP foods, and that can give you some relief. It isn't going to kill the SIBO, it's going to give you relief. And the thing is that you start narrowing more and more and more, and you're taking out foods that your body needs to be healthy. So when we start restricting, not because of weight, but for other reasons, that's something to look at and get help with.
Yeah.
Yeah.
Here, here. We could go all day talking about this, right?
Yeah.
I completely agree. Yeah, it's so important and so missed. People are just like, oh, well, I'm just starting to get some heartburn. I'm gonna start taking the
No.
PPI medications
No.
and all the Tums, and it's like, no, no, you're killing your stomach acid even more.
Okay, so PPIs are a
Hmm.
risk factor.
There you go. Yeah, yeah. Which if people don't know, the antacid
Yeah,
medications,
yeah.
yeah, that just decreases your stomach acid and then decreases your digestion even more.
Mhm.
Yeah. And on that note, any other things that you see really commonly, like mistakes that women are making that are maybe negatively impacting their bone health? Anything that we haven't mentioned yet?
That are the only thing I would maybe put out there. Let's say you come back with a DEXA that's showing you, a negative 3.5 or 4. Okay, so you've got some significant amount of osteoporosis. First of all, don't give up. Okay.
Hmm. Hmm.
We can turn a lot of that around. But some of the more, like wearing a weighted vest probably isn't in your best interest
Hmm.
because it's going to put stress on, especially if you have it in your spine, it's going to put stress on that whole area there. And it's going to probably make it worse than better.
Hmm.
So, be guided when it comes to body movement when you're starting to show something over a -3, I would say. Yeah.
Hmm. That's such
I
a
think
good
that's
point.
really the only thing that I would add to that.
Yeah.
Running is probably not advisable.
Yeah.
Uh,
Even thinking
yeah,
about like little stress fractures that you can get
yeah,
in your
yeah,
legs and stuff. Yeah.
yeah. And
Okay.
by the way, if you're starting to have little fractures here and there and little broken, it's like you didn't do hardly anything and you haven't had a DEXA scan, get your little patootie right in there
Mm-hmm. Mm-hmm.
and get it done. Okay. Because
Yeah.
that shouldn't be happening.
Yeah.
Yeah.
And I appreciate the point too. We didn't really talk about like osteopenia versus osteoporosis, but yeah, it's, you talk to your doctor about if it's like, what your score looks like, if it's looking negative like that. But I'd like that you highlight the point that it's not too late. Even if you have frank osteoporosis, you can do things like all the things that we talked about to improve it. And maybe there are other things, that they're going to recommend too, like the bisphosphonates and things like that if things are really far gone. But I think that's such an important point that it's not ever too late. Yes, the earlier the better to do something
Yes.
about it, but
It's
you can
it's
also
harder.
fix
Yeah.
around later on.
And I do want to just put this in here because it happened to me personally, and I want your listeners to hear this because we will run into it, unfortunately, way more than what we should. Okay. So I had my first DEXA at 66 a couple of years ago, and it was just barely going into the osteopenic in one area. It's just like I'm doing good, doing
Mhm.
good. And I don't know if that doctor really ran my DEXA scan or not.
Hmm.
But the result of the phone conversation, not looking at me, right? Probably
Hmm.
not looking at my chart, really. Her recommendation was take more calcium and put me on a biphosphonate.
Oh, wow.
That's when I said, we are done. Yes. But just the fact that a doctor would do that whenever any practitioner puts out that you need to be put on a medication, I'm hoping that you have someone in your sphere who's knowledgeable, who you can run that by. There are times when that is appropriate, but
Hmm.
there are times when it's not. This was very inappropriate. But I'm sure I'm not the first that she's done that to. And there are definite big risks to using a biphosphonate or any of the
Hmm.
bone drugs. So I just want to reiterate to your listeners that step back, take a breath, you're okay, and get a second opinion.
Hmm. Yeah.
Yeah. And
Wow.
maybe not chat
Yeah.
or Google, but a real person who knows. Okay, please.
Yes. Yes. Yeah. Because again, there is so much nuance to look at everything and
There
really
is.
talk about your lifestyle and talk about the risk factors you've had.
Yes,
Wow, yeah, that is
I
wildly
know.
appropriate and scary because, yeah, bisphosphonates can strengthen your bones, but they can also make your bones more brittle, which I think a lot
Yes.
of people don't know. And
Yes.
so that isn't the end all be all best solution. Yes, it's a
Mm-mm.
worst case scenario. Yes, like if you really need it, can
Yes.
help, but these
If
other
that
things can be really
CTX is up
powerful.
really high and you have significant bone loss, that I would say would be an appropriate stopgap, right? While
Hmm.
we're working on everything else.
Yeah.
So again, taking everything as a whole
Hmm.
picture and in context. Yeah.
Yeah, yeah. And to go back a second to what you said too about the weighted vests,
Yeah.
they got so popular so
I
quickly. And I
know.
think you're right that we should also be mindful about, especially if you have back problems. I have people
Yes.
where they just go into like a 20-pound weight vest and they're hurting their back now. And I'm like, oh gosh, no. And to my knowledge, I think to date, we don't have that great of evidence still that weighted vests
We don't.
can help with any of these things, even though
Yeah.
logically we think that it
Yeah.
could.
Yeah.
So yeah, I think bottom line, if people like it, fine, but
Mm-hmm. Mm-hmm.
maybe focusing a little bit more on the muscle strengthening and the core
Mm-hmm.
strengthening, especially
Mm-hmm.
first if you're just getting into doing more of these things.
Mm-hmm.
Just like
Mm-hmm.
jumping, like jump rope,
Mm-hmm.
trampoline,
Get on a
whatever, like
rebounder.
those little
Yeah.
things. Yeah. Yeah.
Skip. When was the last time you tried to skip? I tried skipping the other day and I went, geez, I need to practice this.
I know I can't keep up with my kids and skipping near once we're not kids
We
anymore, it's a
lose
whole different
that. It's
yeah,
like
yeah. But it's fun. I love it.
it is.
There's
It is
always room
fun.
for some more play and fun in our life.
Yes, there
Awesome.
is. There is.
Well, this
So
is so helpful. I think again, you've brought so many incredible highlights to this where people will get a deeper understanding of what they can really do to best support themselves and advocate for themselves. So I
I
really
hope so.
appreciate this.
My
And,
pleasure.
where can women find you? You mentioned you have a program now.
Mm-hmm. Mm-hmm. So I do have a YouTube channel, and there is a video that I've done, and this comes to hormone replacement therapy. It's just, I think, a really nice overview touching on a lot of different areas. So people do have that theory. Women do have that understanding. So, and that's under my name, Cindy Dupuis. And then I have a Instagram that I put quite a bit of content on that. And then I do have and that's at Cindy underscore Dupuis, Dupuie. And then on my website, you'll find my 8-week Grace and Transition course. You'll find the description about that. And it's done in a community, so I keep it fairly small. It's 8 week. I think we cover in menopause and HRT and blood work and how environment affects us. We do have a movement accountability group as well. That's part of the program. I also, if you think this would be helpful, I don't know if I sent it to you, but I have a PDF and it's a lab checklist
Hmm.
for the pause years. So the labs that I think are really important for women, why they're important, and how to ask your doctor. So if I haven't sent it to you, I can send you that link. So those are the ways, and on my website, you can find out how to work with me one-on-one as well. So
Awesome.
those are the
Well, I'll
ways.
link to
Yeah.
those in the show notes so people can have
Okay.
those right there.
Great.
Awesome. Thank you so much for taking the time and sharing all this wisdom with us.
My pleasure. Thank you very much for having me.